we are now, we are wishing you are going to enjoy with us this very scientific evening and this session entitled Choose Wisely. The agenda is very much interesting for pediatricians as well as for pediatric hematologists, oncologists. I have the honor to be a co-chair in this session with eminent figures. Our guest, Professor James Basil, and let me introduce in extremely short Professor James Basil. Professor James Basil is a professor of pediatrics and pediatric hematology oncology, interested also in general hematology oncology, and he is a leading scientist in maternal and fetal medicine. He is a professor at the Weill Cornell Medicine in New York City. He has focused his clinical and research interests throughout his distinguished career primarily on immune thrombocytopenia, fetal and neonatal thrombocytopenia, and he has more than 400 manuscripts published, largely on thrombocytopenia. He is principal investigator of numerous clinical trials in ITP in children and adults, and he played a strong role in many of the clinical trials leading to advancement in the management of immune thrombocytopenia. You are always welcome, Professor Basil. And I have the honor to be also a co-chair with distinguished colleagues, Professor Assam Abdul Wahed, Professor of Adult Hematology Oncology and the head of the Adult Hematology Oncology Unit, Ain Shams University, and Professor Ahmed Mansour. Professor Ahmed Mansour is a professor of pediatrics, pediatric hematology oncology, and head of the pediatric hematology oncology unit, Mansoura University. And we are going to have a very rich agenda. And let me to start by introducing our guest speaker, Professor James Basil, discussing newly diagnosed immune thrombocytopenia. You are welcome, Professor James.
Thank you very much, Dr. Tantawi, Dr. Professor El Alfi, and the rest of the members of the distinguished group. I've always had a great fascination with especially Egypt, but travel in general. And I look forward to talking about newly diagnosed ITP. These are my disclosures. I guess you could say because I have a lot of them, no one of them is that important to me, and that's probably fair. I think all of you know that ITP was developed as an autoimmune disease over time, and that the so-called Harrington-Hollingsworth self-experiment was when they gave themselves plasma from patients with ITP to prove that the thrombocytopenia was caused by something in the plasma, later shown to be antibodies, and not to be a result of direct bone marrow failure. We know now that ITP is a combination, and I know this is a very sophisticated audience, so I'm just going to very briefly that it's a combination of increased platelet destruction, but also of inadequate platelet production. And in general, we think that the mechanisms that attack the platelets also attack the megakaryocytes. We know there's a lot of bleeding manifestations, and as was mentioned, by far the most serious is intracranial hemorrhage, which fortunately is very rare, but is possibly in part rare because of treatment being administered, and we'll come back to that. So the first consideration for newly diagnosed ITP is the diagnosis, and I highlight our review just because in that review we were discussing refractory ITP, but literally half the review was devoted to diagnosis of ITP. And in both adults and children, there are many things that can resemble it. So there are a number of tables that suggest what some of the other options might be. Now, you could say this is my choose widely slide, because in yellow over here are the only things that are really consensus, where everybody would do this for all their newly diagnosed ITP patients. 2 of them are obtaining a history, another's a physical exam, and for lab tests, pretty much the only one that's mandatory in all cases is the blood count, as long as that includes a review of the peripheral blood smear. Now, many things are recommended in other settings and may be needed in other patients. And for example, in an adolescent female, other autoantibody testing might be required. Many people, including myself, think measuring immunoglobulins is important, and we'll come back to these, but there are a number of different things that may need to be measured depending on the patient. This is taken from work put together by Doug Seens, and the reference here is wrong. It should be Blood 2009. Couple of things that are important are, increasingly we recognize that children who present their ITP at a younger age and or who have in any way complex diseases may be likely to have underlying immune deficiencies. And that doesn't mean that they have to present with infections, but that they may have an abnormality that is important to uncover, because it might indicate the likelihood of chronic disease, and because it might have a very specific treatment available to it. So I don't have time to go over a lot of the individual ones, but some of the more obvious ones, common variable immunodeficiency or hypogammaglobulinemia, is an area where sometimes giving IVIG for replacement is important. Evans syndrome and autoimmune lymphoproliferative syndrome are areas that seem to particularly do well with sirolimus or mycophenolate mofetil, and where you might or might not want to avoid rituximab. So these are some things to consider. In the case of ITP, it's important to remember that for every 9 cases of ITP you see, there should be another one that's an inherited platelet disorder. And unfortunately, they do not typically come with little signs that say, hey, I have an inherited platelet disorder. So they have to be thought of. I've asked Carlo Baldwini, who I think is the most distinguished person in that field, how you would distinguish them, how you would identify them. And he said the number one way is looking at the smear and seeing too large platelets. And I think for the panel, when we were training, we were told to look for large platelets because that would say it wasn't leukemia. But now I think we have to also be aware that if there are too large platelets, that might suggest an inherited thrombocytopenia. Another issue there is that when you make the diagnosis of an inherited thrombocytopenia, aside from whatever is required for the thrombocytopenia itself, there may be other implications. And some of these are listed here. To me, some of the important ones, for example, for RUNX1, include the fact that this may be a patient who's got a relatively good platelet count, 80 or 100,000, but they may be having signs of bleeding or bruising. So it's been my practice since I became aware of that to see those patients, even though they have a good count, rather than letting somebody call me, say, hey, I have a patient with a platelet count of 80 or 100,000. Should I do anything? And rather than just blowing it off immediately, at least trying to get a little evaluation of them to see. Now, I am not sure exactly how things break down in patients in various countries like Egypt. I think I'm pretty confident what I'm saying would apply to Western Europe. Now, what about individualized treatment strategies? Well, the most important thing, to borrow from Shakespeare, this is not my creation, to treat or not to treat. And I think there's pretty good consensus now that perhaps 80% of children, at least, depending on how you define it, when they present with ITP, do not need treatment. And we will go over the ASH guideline recommendations, but these are some of the reasons that might make you want to treat. Many people are sensitive to a really low platelet count. I would confess that I am, but probably bleeding itself is more important, risks of bleeding, and it's important not to ignore quality of life. And especially, I think, in little kids, rather than being fatigued, they're irritable, like the way they might be if they don't get to sleep when they should and they're tired, but they don't know how to tell it to you. A very important study is the so-called Tiki trial from the Netherlands. This was conducted from 2009 to 2015, and 200 children were randomized to either receive one dose of IV gamma globulin, 800 milligrams per kilogram, or no treatment. In the 100 who didn't get treatment, 8 had to be hospitalized within the first month for bleeding, and 1 had an intracranial hemorrhage. What was important was that all of these patients had grade 3 bleeding, I think except 1, at diagnosis. So that to me is where the 80% number comes from. About 20% of the patients would have more bleeding than petechiae and ecchymoses, and those are the ones you might want to think about treating. The flip side is, in the 100 on IVIG, there was only 1 hospitalized for bleeding, and the platelet counts got better sooner and stayed better with that 1 treatment. Now, in this study, 5 patients had major reactions to IVIG, 4 headache and 1 allergic. But it's important to remember that no pre-medications were given. And there's been a recent study from Canada showing that administering steroids with IVIG will allow patients to have less in the way of headaches and reactions. So I'm on the side of the fence that says, if you have grade 3 bleeding, maybe that 20% or some other major concern, that treatment is appropriate and would be beneficial. On the IVIG arm, earlier remission was seen at 1, 4, and 12 weeks. It wasn't significant, but the patients still continued to be at least a little better at 6 months. It was only at 12 months when there was no difference at all, possibly because of the infrequency of development of chronic ITP. Now, there's a tremendous emphasis on not treating too much, and that is very important. And I think that I hope I laid out the case for you that at least 80% of children probably don't need treatment. There's many other factors that we'll come back to, though, that may have you treat somebody who medically may not fully require it. But the flip side is, you don't want to undertreat the ones who really need treatment. And part of that is not only recognizing that they need treatment, but also recognizing that you may need to not be satisfied with just starting them on steroids or just giving them IVIG, but to pursue treatment till the platelets go up and the bleeding stops, even if that means using multiple treatments in a relatively short period of time. Now, there's some concern about steroid use in the treatment of ITP. And what I would point out to you is, I'm sorry, I went the wrong way here. Sorry. There we go. There's a very nice study from Sick Kids in Toronto where if you had patients who looked like they had typical ITP with normal white counts and red blood cell counts, and obviously nothing amazing on exam, no cases of leukemia were missed. Even in cases where the white count was low or high and you said viral infection, hemoglobin was low, you said bleeding, bone marrow is only revealed less than 10%, about 5% of cases of leukemia. But I think it's important to take this into account if you use steroids, which is now widely used and very appropriate. There's changes in IVIG. Some of the preparations now have lower levels of anti-A and anti-B, meaning less hemolysis after, and there's less risk of thrombosis as well, with the attention to lower levels of factor 11A. I'm going to skip anti-D. I'm not sure if that's available to you. I would point out here that when you're thinking about the thrombopoietic agents, and here this is data for L-Trombopag, depending on your endpoint, whether in the case of Petite it was 1 platelet count, or was more stringent in Petite 2, 6 out of 8 platelet counts, you could get a more significant difference, but you also would get different response rates and certainly different placebo response rates. So if you're reading the literature and trying to decide, it's important to pay attention to these definitions. But the real reason I brought up TPO agents is more and more those are being used up front. And as I will show you, would probably be the first treatment used after IVIG and steroids if they're needed. Now, what about using thrombopoietic agents in pediatrics? Well, first of all, there's an increasing amount of data that says they're safe. Very young children might need higher doses. It's difficult for teenagers, particularly, to follow the diet, but I actually think they're better in pediatrics because of the lesser risk of thrombosis and the lesser risk that the patient has an underlying MDS. Now, I'm going to go through the guidelines quickly just to point out that this was the third set. There were 5 pediatricians on it. And when they made a recommendation that was strong, most of individuals would adhere to it. It's important to point out that whatever the recommendations, they all had very low certainty of evidence. Conditional, you can imagine most people would adhere, many would not. And this especially would emphasize depending on the individual. And I can't stress enough the importance of individualizing care. And there's many factors to consider in that. And finally, the guidelines are not a how I treat, but they are based on assessing evidence, and where data is lacking, it's lacking. What did they say about ITP? Suggesting against admission if the platelets were less than 20 and there was no or mild bleeding. Stronger, recommending against admission if the platelet counts were higher. But I'm sure these factors are of concern for you as well. Social issues, distance from the hospital, getting follow-up. If there's a serious question there, admission would certainly be appropriate. We talked about careful observation, and those are the recommendations for, again, skin bleeding only. non-life-threatening bleeding, where there's enough bleeding, as we talked about, grade 3, they recommend steroids, and they say don't use them for more than 7 days. In other words, high dose, early treatment, early cessation is important. The guidelines suggested prednisone. It's true that it seems that dexamethasone is not as good in children, but I think that's a very soft recommendation. Second line, probably going to a thrombopoietic agent before you go to other agents, though I would argue if you had an adolescent female, rituximab would be particularly good to use. Now, I finished my presentation, and I know we're going to do, I believe, questions later. I would just say that the next speaker, who is Professor El Alfi, has had an extremely distinguished career and has had a major impact in Egypt and across the world in doing studies in ITP and advancing the understanding and ability to manage and treat patients with it. Now, saying that undersells the fact that he's had a lot of other disease impacts also in, for example, thalassemia and sickle cell. But it's a great honor to participate with him. And I should say also that I had the pleasure many, many years ago of meeting Professor Khalifa, and it's great to be able to think of him here today as well. Thank you.
Thank you, James. It is my honor to speak after you and to be in the same panel with you. This Choose Wisely ITP Management is the Professor Khalifa lecture. Professor Khalifa has his fellowship in Wayne State University, Detroit, Michigan, and he works with Professor Zulzer and Professor Jean Lasher, and he published maybe 4 decades ago the immunoglobulins in ITP before Professor Paul Imbach has first publication in Lancet about the use of IVIG in ITP. The headquarters of Ain Shams University, I have no conflict. These are the heroes. We wait every year to see the names of Nobel Prize winners, 2019, 2020. And the youngest winner was 32 years old. The oldest is 87. And here is the coming champ for Nobel Prize. He was awarded the Arab Nobel Prize a decade ago, and he is a candidate for Nobel Prize. ITP publications, Egypt shares only with 1%, which is the same as our population in the general population of the globe. Ain Shams University has 1/3. I have 20 publications. Professor Khalifa had the first publication in ITP in Egypt. James and Paul Imbach are the top publishing on ITP. Guidelines and consensus are still the most cited publications. Primary ITP is an acquired autoimmune disorder, isolated thrombocytopenia, as James said. The most common hematologic symptoms, bruising and mucous membrane bleeding. Fatigue, we never ask about fatigue, but it is very important, fatigue and fear of bleeding with poor quality of life. However, secondary ITP, usually the underlying symptoms are more prominent. Diagnosis of ITP is one of exclusion. Hereditary non-immune thrombocytopenia should be excluded in young age. Babies less than 3 months, we should suspect autoimmune or alloimmune thrombocytopenia, will be addressed beautifully by the most famous in the world publishing on that subject. Secondary ITP, lupus and antiphospholipid syndromes are more common in young adults and adolescents, while common variable immune deficiency should be suspected maybe in refractory cases. HIV is very rare in Egypt, hepatitis C in adults, and presidential campaign to eradicate hep C is very promising. This is Shayma. She came to my attention a month ago. Good hemoglobin, very low platelet count, and minimal symptoms. ESR is normal. No symptoms suggestive of lupus. Immunoglobulin is, say, very low IgG, IgA, IgM, and she is a common variable immune deficiency. Initial lab is completely agree with James. Only good history taking, family history, drug intake, viral infections, vaccinations, herbals, but CBC and good look for the peripheral blood smear is very important. Completely different from non-responding case. Non-responding case, we have to re-evaluate the condition, look again for the blood smear by an expert for giant platelets, platelet aggregates, fragmented red cells. Blast should be clear from the start. Bone marrow aspiration should be done. In the initial evaluation, it shouldn't be done in classic case, but in resistant case and prior to splenectomy, which is very rare in children, should be done, and the report should be done by an expert. The initiative of the ASH, number 10, don't treat patients with ITP in absence of bleeding or in absence of very low platelet count. We have to choose between fruits. Anyone know which fruit? This is called bashmala. I think it is not in Europe. And this is mango, and this is oranges, and this is peaches. And when we choose, we look for harm avoidance, evidence, cost, relevance, frequency, and impact. So when you choose even fruits, you look if it causes you allergy or diarrhea, and the evidence for that, is it very expensive, not, and so on. Stop doing unnecessary bone marrow aspiration in classic ITP or repeated high dose of steroids as if it is peanuts. Prolonged use of steroids more than 6-8 weeks is a crime. Repeated unnecessary CBC, unnecessary hospitalization, high cost treatment unless indicated, and keep good quality of life. Bone marrow aspiration is unnecessary in typical cases, and it is essential in refractory cases. Bone marrow aspiration is done in 8% 2 decades ago in USA, and last decade in 6%, which are the resistant cases. Bone marrow aspiration should be done in if there is refractoriness to therapy. This bone marrow picture. We stop doing unnecessary hospitalization. Total annual hospitalization in ITP in USA is 6 per 100,000, and no much difference over the last 2 decades. The lowest proportion in August, and actually ITP is less presented in August. Cost of treatment, $6,000 over 4 days 2 decades ago, $9,000 in 2.5 days recently. IVIG was more popular in the last decade, 40% of cases, compared with in the early 20s, and it is less commonly used now. High cost treatment is not practical in Egypt unless of great value. This is another case with platelet count of 4,000. Again, hemoglobin is okay, total leukocytic count is okay, and this patient, as we can see, has a high total leukocytic count, but no blast, nothing, and no symptoms suggested. This is a newly diagnosed ITP. After IVIG, she showed a very good response to platelet count. This is another case, Fayrouz. She is 7 years. She presented with picture look like peripheral bicytopenia. Platelet count 20,000, total count is 2.1. We have a lot of differential diagnosis, but actually this patient received thrombopoietin receptor analog, Revolid, and the white cell count jumped to 5.5 and hemoglobin to 13, platelet count 600. We stopped the treatment just for a couple of days. We followed the guideline. We reduced the dose, but the platelet count dropped a little bit, and we have to go up from 25 to 50 milligram. And she is beautifully responding both for the white cell count, and I didn't put her last CBC, white cell count and platelet are perfect, and she is on 50 milligram. We have to address the problem. We have to have proper diagnosis. No ITP in the first 3 months of life. In refractory thrombocytopenia, you have to reevaluate your case. It might be congenital thrombocytopenia or thrombasthenia, especially Bernard-Soulier. Of course, we have not to miss any acute leukemia or bone marrow failure. The problem with acute leukemia, if somebody starts steroids, may be missed by any even of expert hematologists. Harm avoidance, don't give unnecessary treatment. Don't give too much steroids, except if there is serious bleed. And methylprednisone, I published the dose of 10 milligram, one dose, maximum 2 doses. No need for 30 milligram per kilo per day 3 times, and then 20, then 10. And we can discuss this with James at the end of the presentation. Intracranial hemorrhage, James has a lot of publication. We have a couple of publications too, multi-center. All the centers in Egypt joined the second publication, and the mortality looks like the American experience, 20-25%, and morbidity 20 to 25%. Abdurrahman presented his 14 years old, but he has 3 intracranial hemorrhage. He is chronic case, 10 years with ITP, platelet count 1,000, and he developed intracranial hemorrhage for 3rd time. He is 16 years. With another case, Muhammad, 14 years, the second intracranial hemorrhage. He was operated with tryptophan and they evacuate the hematoma. He received the backup with IVIG, high dose steroid, platelet, and thrombopoietin receptor agonist. Intracranial hemorrhage costs around $40,000 in 8 days with mortality of 20%. And the important publication in Blood a decade ago of 40 intracranial hemorrhage with mortality of 25%. Intracerebral hemorrhage is much more common in adults, 4 times in adults than in children. However, non-intracranial hemorrhage is more in children, double. 20% of children have severe non-intracranial hemorrhage in contrast to 9% in adults. We have to avoid trauma, give confidence to the child. The family shouldn't be overprotective, and we let them know which they should not play it, and keep good quality of life. How to predict chronic ITP? Age above 10 years, platelet count initially 40, 50,000, very slow onset. However, Thomas Kuhn, a friend from Basel, mentioned that the age of 6 to 12 months has the highest likelihood of remission. Goals of therapy to prevent major bleeding, cure some good proportion of cases, modify natural history if you can. And there is overall a decline in the use of platelet enhancing agents for the early ITP case, especially those responding to treatment. Splenectomy is rarely done now, maybe 1% or less in refractory ITP. And we have the role of repeated short courses of steroids or repeated IVIG. However, TPO receptor agonists could be of value, easier to use, still expensive, rituximab in selected cases. The risk of life-threatening infection with a splenectomy, especially if you receive rituximab upfront, cost-effectiveness analysis for 2 TPO receptor agonists is of value and cost-effective in risky refractory cases. Take-home message: don't get panicked if you find platelet count 20,000. Some of them, they don't have severe bleeding. Decision to do bone marrow aspiration in non-classic or in refractory cases. Hospitalization should be a little bit limited unless there is a serious bleeding or fear of the family cannot take care of the child. Don't abuse a steroid, either high dose or prolonged use. Don't give expensive treatment unless indicated. This is the hematology team in Shams University, Professor Abdel Gawad Tantawi, Professor Mukhtar, and actually Marwa and Khadija were helping me in the past with the ITP cases. The choice: do you want to be one of the Queen Victoria Royal but have hemophilia? You have to choose. Do you want to be like Tut, a king, but he died at the age of 16 years? I choose to be a son of my father who has a great awards, and he gave me the will to do what I need to do. And this Boursaid, we are going tomorrow. I hope the weather will be better tomorrow. We have bad weather today. King is asking everyone to visit him in the new palace. You are welcome, James, all the time to come to visit the new museum. And thank you very much. Professor Assam will introduce Professor James Bossel for the second presentation. And James, please share your presentation. Professor Assam.
Thank you, Professor Mohsen.
Maybe Professor Assam has audio problem. So James will speak about fetal and neonatal early immune thrombocytopenia. He is the top of the top. He has more than 100 publications in that subject, and he paved the way for the others to go for that. Professor James, please go ahead.
Thank you very much, Professor El Alfi. And this is the other area that I've had the pleasure of working in. I started seeing patients with this when I began my career in 1981, but then it really got activated in 1983. So it's more than a 35-year saga now. And I will try to bring you up to date briefly in this, and then talk about new developments that will hopefully impact the way we look at this in the future. I've worked essentially my entire professional life with Jan McFarland and Dick Berkowitz, so I'm really presenting for the three of us. Those of you, which I think is virtually everybody who work with pediatric patients, know there are very many reasons to have neonatal thrombocytopenia, and I'm sure that I've left out a few even on this very busy slide. What is alloimmune thrombocytopenia? It is the platelet equivalent of Rh disease. The mother lacks a platelet antigen possessed by the father. That's most commonly HPA-1a, used to be called PLA1. She's exposed to it by fetal platelets. She makes an antibody to it. This IgG anti-platelet antibody crosses the placenta, destroys fetal platelets, inhibits fetal platelet production, and results in often early severe thrombocytopenia. So these are some of the many antigens involved. There's at least 33 now known. I don't know, and I'd be happy to hear comments on how in Egypt and elsewhere people actually accomplish testing. By far the most important, and this is borrowed from Peter Newman, who's doing some really exciting work in the field with a mouse model. This is PLA1 or HPA1, and at least 75% of cases, and especially severe cases, are caused by incompatibility of this antigen. In Eastern Asia, then you don't see polymorphisms of this, so there's no incompatibility, and the PEN, YUC, or HPA4 becomes the most common. Next most common is BR or HPA5B, but fortunately that tends to be milder. This is typical testing from Milwaukee in a couple that's affected. The mother is HPA1B1B, meaning she doesn't have HPA1A. Here the father's a heterozygote. Most fathers are homozygotes. You see other antigens tested also, and her antibody is specific for glycoprotein 3A in an HPA1A positive individual, control platelet. So you can be pretty confident about identifying the antibody in a good laboratory. So why are we focusing on this with all those other causes? It's by far, fetal and neonatal alloimmune is by far the most common cause of intracranial hemorrhage in term neonates and of severe thrombocytopenia in all neonates. There are also special considerations about it. It will recur in the next affected pregnancy, and typically it will be more severe in those cases. And in addition to anyone with severe thrombocytopenia as a newborn getting platelets, they may require IVIG as well to manage the neonatal thrombocytopenia. This is from a publication on comparing 111 patients with fetal and neonatal alloimmune to 56 others who were tested but did not have it. And the single best diagnostic feature was a platelet count on day one less than 50,000. Importance is that failure to respond to random platelets did not actually determine diagnosis, so that should not be used. And it's important to follow the platelet count until it normalizes, since otherwise it's possible to miss an inherited thrombocytopenia. The day one platelet count, if it's less than 50,000, you're going to identify 90% of the FNAIT babies. On the other hand, they will be up to 50% of all of those babies. Flip side is if you use a count less than 20,000, you'll only identify about 50% of the FNAIT babies, but the clear majority of those babies will have FNAIT. The number two cause is usually CMV or rubella, and I saw that Dr. El-Alfi in his slide talking about ITP had a CMV IgM, and that's a relatively important issue. But because you're worried about recurrence in the next case or in female relatives of the mom, it's more sensible to use a more inclusive, even if less specific, criteria for identification. Obtaining radiologic evaluation as to whether or not there's an intracranial hemorrhage is very important for the same reason. Right now, as shown in a nice study from Germany with one center in Canada, random platelet transfusions are the mainstay of treatment. Giving IVIG with them is helpful. We rarely use matched platelets. And there's probably a role for steroids, but we are concerned about the risk of predisposing to sepsis. You see here an affected baby, loads of petechiae and ecchymoses, had no other findings except for a platelet count of 3,000, died at the end of the first day of life, and was important because the intracranial hemorrhage that this baby suffered had started 6 weeks prior to birth. You see here a large intracranial hemorrhage on an MRI, and it's important because if you get a sono or an MRI soon after birth, you can say whether or not the hemorrhage occurred prior to birth. In FNAIT, at least 3/4 of the hemorrhages are not due to head trauma at delivery, but occur in utero. And this is very important for management of the next pregnancy in the mom. I'm going to skip over why I got involved with this. And just to say that when that mother, and this is where we've done a lot of work, but that's not really pediatric, it was going to deliver her next baby with a previous sibling with an intracranial hemorrhage at 32 weeks, we could not say, oh, we'll just do an elective cesarean section at 37 weeks, because the baby would have every expectation of having a hemorrhage by then. And that's how we started doing management of the mother. This is our first publication from the New England Journal in 1988. and it illustrates a number of important things about fetal and neonatal alloimmune. First, you see that even as early as 20 weeks of gestation, thrombocytopenia is very severe. And in our data from our first 100 patients, we found that 50% had counts less than 20,000 by 24 weeks of gestation. Normal is the same pretty much at all ages, above 150,000, whether you're a fetus, an infant, a toddler, a child, an adolescent, or an adult. So these already show very early in gestation severe thrombocytopenia, explaining why there's a high risk of in utero intracranial hemorrhage. The second thing is that in this baby who had a platelet count of 128,000 at 22 weeks, we did not know what would happen because this was very early. So we waited and watched and repeated fetal blood sampling at 28 weeks, and you can see that the platelet count was down to around 20,000. The solid lines represent treatment, showing that with the treatment, the fetal platelet count would go up. And that's how we got involved in that. And I'm not intending to talk more about it, but I'm more than happy to answer questions. So we know that this occurs in about 1 in 1,000 infants. We know that it's not always severe, but can often be severe. We know that there's a rate of intracranial hemorrhage in severe cases of 10 to 20%. And we know that most of those are in utero. And we know that if you identify such a case, you could provide treatment to the mother during the next pregnancy in order for her not to have a recurrence. Now, what is going to change in the future? Well, there's now a movement and studies ongoing supported by a company named Rally Bio that took over the studies of a company called Profilix Pharma. And the idea would be to screen all pregnancies to identify the 2 to 2.5% of women who are HPA-1b, 1b. Then it will be possible to do cell-free fetal DNA typing of the fetus to find out what the fetal platelet type is. We can do typing for DRB3-0101 on the mom because in general, if the mother is HPA-1b, 1b, if she does not have DRB3-0101, the chances that she'll become sensitized and have a severely thrombocytopenic fetus are very, very low, despite her being at risk for it. There are studies to develop NATEGAM. You could think of it like RhoGAM or an antibody to Rho-D, which would be prophylactic to prevent sensitization in women. And on a separate note, there are studies to look at inhibition of the FCR, the neonatal FC receptor called FcRn, to block transfer of HPA-1a across the placenta. So I'm going to review these briefly. If the mother does not have DRB3-0101, we would consider her not to be at high risk at all and not do any management other than monitoring, even if she's HPA-1b, 1b. This is crucial for screening and then later prophylaxis. Of HPA-1b, 1b women, only about 1 in 4 express DRB3-0101. So this would mean that only about 1 of 200 screened women would be at risk to have a fetus with severe FNAIT. I would point out to you that in RH disease, 15% of women are RH negative. About a half of them will have an RH positive fetus, or maybe even slightly more. So you're giving RhoGAM to 5 to 8% of the population, whereas we're talking about here giving NATEGAM to 0.5% of the population. There's one lot of NATEGAM that's been made. Studies in mice look like it's reasonably effective. I should tell you that we still don't know how RhoGAM works. Why giving anti-D to an Rh negative woman prevents her from making her own anti-D. So it's a little bit of a leap of faith here that this will do the same thing, but it seems likely to work. And Peter Newman, who I mentioned previously, has developed a mouse model where they've done 4 and 5 amino acid substitutions to create the equivalent of an HPA 1b 1b mouse that can be studied and looked at in preclinical studies. Now, shifting to FcRn, FcRn binds IgG only at acidic pH. So the way we think of this as working is that plasma, including IgG, gets taken inside a cell and is in an acidified endosome. Because it's acidified, the FcRn that's on the inside layer binds the IgG, and then it transports it out to the surface of the cell. At the surface of the cell, the pH is physiologic, and therefore the IgG dissociates from it and returns to circulation. This process is accelerated if, for example, you have a platelet with an antibody on it that is brought into the acidified endosome by a surface Fc receptor, not FcRn. Now, what's described here is the way it recycles normal IgG. So, for example, currently, FcRn inhibitors are being explored for IgG-mediated diseases like ITP, like myasthenia gravis, like pemphigus vulgaris, where by lowering the IgG level dramatically, you can lead to lowering the autoantibody IgG and make patients better. And in fact, that has been seen. But it is also the only way that IgG goes from the maternal side of the placenta to the fetal side of the placenta. And therefore, blocking FcRn should be even more effective than IVIG at preventing transplacental transfer of IgG. So another benefit, in addition to blocking transfer of the maternal IgG anti-HPA-1a, is that it also lowers the level of this antibody in the mother. So you have a two-pronged effect to do this. While there are 4 or even 5 anti-FcRns in clinical trial, there is one that's in trial for hemolytic disease of the fetus and newborn for Rh disease, and that's been highly effective in very limited, very preliminary results. So this likely would become the treatment of choice in cases of fetal and neonatal alloimmune, where at least right now there is not prophylaxis. So what would ideally happen in the future? All pregnancies would be screened. You would identify the women who are HPA-1b, 1b. You could use cell-free fetal DNA to determine if the fetus would be affected. You could use for HPA-1a DRB3 0101 to see if that mother is really at risk. And then those women would receive NATEGAM or equivalent to prevent them from being sensitized and being affected. Now, in my fantasy, in the setting of screening and prophylaxis, the number of cases of fetal and neonatal due to HPA-1A incompatibility would fall considerably. But for many reasons, as happens with RH, there are cases where prophylaxis fails, and there are many other antigens that could lead to fetal and neonatal alloimmune. And therefore, for those cases, blockade of FcRn to prevent transfer of mothers' antibodies to fetal platelet antigens across the placenta would be not only, we hope, extremely effective and very safe, but also much easier on the mom during the pregnancy. So thank you very much for the opportunity to talk about this also. This is the front entrance of Weill Cornell in New York, and there are many, many people who have contributed to this work that I have to thank. Thank you again for the opportunity.
Thank you, James, very much. And please keep till the end. Sharif will not talk too much. It will be 15 minutes. Then we open the floor for a couple of minutes because we are a little bit behind the schedule. Sharif Badawi is assistant professor from Chicago. He has more than 100 publications in cancer and in blood and in all journals. God bless you. And he has a leading role in the program of Choose Wisely. And he will tell us 5 tests you shouldn't do, or whatever you would like to say. Sharif, please share your presentation.
Thanks, Professor Alfie, and thanks for the kind invitation. I'm just sharing my slides in a second. And really good to see you all. And I'm, I have to start by saying that acknowledging a few of my mentors, actually, when I used to be at Zagzag University. So Dr. Tamer Hassan, Dr. Usama Safi, and Dr. Laila Sharif, I really owe them a lot in my career, and they are the one who made me fall in love with hematology and oncology, and that's where I am right now. So I really owe them a lot as my first mentors, from clinical standpoint or research. Actually, my first paper was ever with Tamer. And it's not a 100 paper, Professor Mohsen, but I'm definitely have been doing well here in Chicago. But thank you so much again for the invitation. And I'm presenting this work today to you all on behalf of the ASH and Espho Choosing Wisely task force, and really highlighting some of the items or Choosing Wisely campaign items that focus on pediatric hematology that I felt it's going to be important to actually share with you to make sure that you try to apply these questions actually and ask them to yourself and your colleagues when you do that so in practice. So what is it Choosing Wisely? It's an effort that is really kind of led by the American Board of Internal Medicine, asking all professional societies, including American Society of Hematology, American Society of Pediatric Hematology and Oncology, and challenging them to really identify the treatment and the procedure that they should actually question and maybe not do anymore if there is any issue related to cost, and prioritize frequent assessments and definitely clinical circumstances as well as evidence. They did this with the American Academy of Pediatrics, American Society of Clinical Oncology, and really all American board organizations to try to identify these questions that are relevant to the subspecialty. ASH actually added another item to look at, which is avoidance of harm. So evidence, cost, frequency, clinical purview, and avoidance of harm. So these are the 5 questions that we really have to look at as we are evaluating these tests and assessments. So ASH and Espho bounded together and formed this task force to try to get into the pediatric hematology list. What
you find difficult to share your presentation? We are not seeing your slides.
Oh, I'm sorry. I'm sorry. I shared, but I don't know why it didn't go. Sorry about that. Sorry, doctor. Can you see it now?
Yeah.
Okay. Sorry about that. Okay. Sorry about that. So we talked about the Choosing Wisely campaign. What is it for? And we talked about evidence, cost, frequency, clinical purview, and adding
Go
harm.
ahead,
Really
go ahead, Steve. Go ahead.
to think about it. And then Ash and Espho identified like 13 members to actually lead this effort. And what we've done is solicit suggestions from different societies, from members in the society to suggest these items. And we started with an 8 semi-final list that look at these 6 principles. And then we came to the final 5 items that has been approved by the executive committee for both ASH and ASFO. So what are the 5 items? The first one is do not perform routine preoperative hemostatic testing, PT and PTT, in otherwise healthy child with no prior personal or family history of bleeding. It's a common practice even here in the US, and I'm sure it's Egypt as well, but there is really no data for that, and we'll talk about it in a second. I guess along the lines with like transfusions and platelets, as Professor Alfie and Professor Bussell talked about it, do not transfuse platelet for really asymptomatic pediatric patients with hypoproliferative thrombocytopenia if they have a platelet count of 10,000 or more. With 1 year of age, that's kind of the criteria to keep in mind as well. So it's not really applicable to everyone in the absence of any bleeding signs or symptoms. And also if you're not anticipating invasive procedure. Do not order thrombophilia testing on children with venous access related clot. So if we know that the clot was not unprovoked, it really came with a central line and there is no positive family history, and that's kind of debatable about what is a family history. There's no consensus about it. But if there is really no positive family history and it's central line, you don't need to do that. And then do not transfuse packed red blood cell for iron deficiency anemia for somebody who is asymptomatic with no evidence of hemodynamic instability or active bleeding. And finally, do not administer routinely GCSF for patients who have asymptomatic autoimmune neutropenia or idiopathic neutropenia if they really do not have any signs suggesting severe or recurrent bacterial or fungal infection. So we'll talk about some of them in some details, but some also will be really quick. So the first one, there is really no data suggests that if you do like preoperative screening with like PT and PTT, that would really help you identify who's gonna have unexpected surgical bleeding or not. There are definitely some artifacts and you may find things that you don't know what to do with, or it can lead to delays in doing the actual procedure that maybe you want to do, because we know like patients who have factor 12 deficiency don't really have much bleeding risk. And sometimes you can have just lupus anticoagulant that make the test abnormal, but patients do not bleed anymore. And then definitely there is cost and stress when you get abnormal results that you have to discuss with the family. And this is one of the studies in ENT that were done that's showing how poor the sensitivity can be in predicting operative bleeding. And you can see that very low sensitivity overall and also terrible positive predictive value. So it really doesn't tell you who's gonna bleed and who's not. And I think the same here, if you look at from the same study, people who had normal PT and abnormal, normal PT and abnormal PT, and how many actually had bleeding during surgery, you see that even it's a little higher for those who had normal PT, and the p-value was not statistically significant. And when you look at the PTT, it's kind of in a similar way, although the percentage was different, that those who had prolonged PTT had a little bit higher bleeding incidence, but still was not statistically significant. In the US, it costs $10 to $100. I don't know in Egypt, but I know it definitely is cost money, whether they have to pay out of pocket or it's covered by insurance or by the government. They may have to pay part of it. And again, it is not a cost-effective strategy. And it's not also, it doesn't really affect quality of life for if you screen patients, then they're gonna feel better about it. And again, when one of the studies did audit for the PT and PTT that were done at their institution, there was really no justification in almost all the cases where they were done preoperatively. So what do the guidelines say? So this is the British Society of Hematology guidelines suggest against actually testing for preoperative setting. It suggests that you should take a bleeding history in the preoperative patients, if they have hemophilia or von Willebrand or other bleeding history in the family. Definitely do screening if there is a positive history, but if not, don't really bother. And no further workup is needed if the history is completely negative. And I think that's also consistent with what is in the literature out there in a number of reviews, that there is no power to predict really bleeding risk. There is no evidence for the usefulness of the PT and PTT. And routine really screening is not recommended for the invasive or perioperative bleeding risk prediction, given that lack of utility. So why choose wisely? I think basically it had cost, it adds stress, it's inconvenient. You may have to cancel the surgery or postpone it. Not all surgical bleeding are really due to hemostasis. You may have some other surgical issues or complications. And bleeding during or after surgery, you can't treat that. And if malpractice is an issue, especially here in the US, you definitely need to take a detailed bleeding history, and you can guide your decision afterwards. And it really is not gonna help you find who's gonna bleed and who's not. The second one is related to the platelets. And it's just focused on really trying not to transfuse asymptomatic patients who are 1 year or older, unless there are symptoms or other risk factors for bleeding. And this specific recommendation is really consistent with all the other clinical guidelines from the National Institute of Health and Care Excellence from the UK, the British Society of Hematology itself, American Society of Clinical Oncology, and the American Society of Hematology for the adult choosing wisely guidelines. The risk of bleeding as a spontaneous bleed is really low when you have platelet more than 10,000. And this unnecessary transfusion, as we all know, can increase risk for transfusion reactions, alloimmunization, bloodborne infections, and refractoriness with future transfusions. So the recommendation does not apply to invasive procedure, and I think I wanted to make this one very clear as well. Why it is important and why we would bother really with choose wisely, because platelets are limited and expensive. And I remember back when I practiced in Zagazig University, I think it was also still limited. And I don't know if this is still the case, but sometimes it's difficult to find platelets. And then, there are some risks. We all know that allergic reaction, febrile reaction, trally, all the reaction that can happen. And then infection, I think screening, I'm sure, getting better and better, but the risk of infection is still there. And alloimmunization is also a consideration. And when you go down on your threshold for transfusion, you definitely decrease the number of transfusion that would be needed. And in a recent meta-analysis, it showed that it can decrease by almost 2 times, actually, the number of units that you would need if you just make a simple intervention by changing the cutoff for when you need to transfuse somebody with platelets. So basically things that you have to consider as well, right? So if you're putting a central line, if you're gonna do like a bone marrow aspirator biopsy, if you're gonna do a lumbar puncture for a patient with or without blast, then okay, you may definitely consider that and decide about what cutoff you wanna use. You may not stick with the 10,000. If somebody on anticoagulation because they had a VTE, then you decide about your cutoff. It may be 40, it may be 50, maybe 100. It really depends on the bleeding risk. People with sepsis, patients who are younger than 1 year of age, or those who are actively bleeding for sure, or recently had an active bleed. So these are kind of clinical judgments, really kind of doesn't apply to the choosing wisely recommendation. Next one is thrombophilia. So basically, if you have a provoked clot and you know that's because of the central line that a patient had, there is really no value of doing the thrombophilia testing for different reasons. One, it does not influence your initial management. If you're gonna treat the patient for 3 months at a minimum with anticoagulation, you're still gonna treat the patient. You may get false abnormal results like protein C or S might be low because they are consumed by the clot. So even if you do so, timing is definitely not ideal. So it is really a recommendation against testing anybody for thrombophilia workup if you have a clot related to a central line. It does not really help you predict if a patient is gonna have future recurrent VTE events or not, and it doesn't change how long you're gonna put the patient on anticoagulation in the setting of a clot. And then definitely financial cost, and I definitely have no idea how much it costs in Egypt, but at least here it is a financial burden for sure. And finally, it's misinterpretation, and you may add psychological distress or kind of childbearing plans kind of disruption in people understanding if they have a risk or not, or they may be mislabeled as they have a thrombophilia risk, but it's actually not true. And definitely also can have some insurance discrimination, at least here in the US as well. I'm sure it's applied in Egypt to some extent. So we know that pediatric VTE is rare. It's more common in hospitalized kids, especially chronic ones. especially with 2 age groups younger than 1 and adolescents. And we all know that Burkitt triad, prothrombotic risk comes with like disruption of flow, endothelial damage, and infection or inflammation. But really 85% of VTEs in kids are really kind of central venous catheter related, period. So it is the most common reason. And when you do like thrombophilia workup, you think of these kind of 9 tests, and the 5 big ones are factor V Leiden, prothrombin, antithrombin, protein C and S. And we know that there is some variation in the published data. And we know that, in a recent meta-analysis by Guy Young showed that there is definitely increased risk of VTE events if you have any of these abnormalities. And you can see the odds ratios here. But I think in this meta-analysis, what Guy Young included like people not specifically for central venous catheter. And I think that's just acknowledging that it is rare, but definitely can increase risk, not in the setting of a central line. So what does the ASH actually guidelines says for pediatric VTE? And the guidelines recommend using anticoagulation rather not if you have somebody with like a symptomatic DVT or PE, and they recommend not more than 3 months, especially if it's provoked. And they also recommend against extending more than 3 months unless there is a reason, and they do not recommend thrombophilia testing because it does not influence your choice of the anticoagulant agent, how long you're gonna be for, or the intensity of treatment itself. And this guideline really kind of consistent with what the British Society of Hematology also suggesting, that there is really no clear benefit of doing thrombophilia testing. And that's also the same for the Canadian guidelines. So take home message, really do not do thrombophilia testing. It doesn't change what you're gonna do. And do it only, or remember that it has financial cost and it has some insurance considerations for some patients. And then the last 2 are really gonna be brief, and that focus on iron deficiency anemia. And the point is, if somebody has a hemoglobin of 5 or 6 and they are otherwise totally asymptomatic and hemodynamically stable and no active bleeding, there is really no point of giving them blood for reasons we'll talk about, because it can increase the risk of complication, right? We talked about the transfusion reaction, bloodborne infections, and volume overload. And definitely also it's a scarce source as well. And it can be expensive to give somebody a unit of blood if you can just like treat it by eliminating milk or birth control for adolescent girls, or just starting iron therapy. So it's definitely a common pediatric problem, 2 billion people worldwide, 5 million in the US. Many people are asymptomatic because it's chronic. You don't get iron deficiency overnight, and your body adapts to it. And the challenge is usually sometime, even if you're asymptomatic, you have iron deficiency even without anemia, we know it can have issues with cognitive function over time, and it's important to also treat that. And if you don't fix the problem, like, if it's milk consumption, if it's heavy menstrual bleeding, if it's whatever, it's always gonna come back. So we really have to fix the problem and then do the iron, but blood is really just more of a Band-Aid for the problem here. And they all work, oral iron therapy works, whether it's ferrous sulfate, we know that has the best absorption, and it can see here on the y-axis, the hemoglobin increase, and this is time from starting up to even 12 weeks, and they're both nicely increasing. We know that the iron polysaccharide has a little bit less absorption capacity, but it still actually works in a good way. And there's definitely now more even trend to try to think of early utilizing IV iron because it is rapid, safe, and effective. And here you can see just like some data from PPC about a couple of studies that looking at non-adherence, malabsorption, chronic blood loss, and what degree of a change in hemoglobin after IV iron therapy. And you have been trying to do oral for quite some time, but it's just not working. And the same was also demonstrated in another study, confirming the safety of really using IV iron, and it can be utilized, after trial of oral iron if it's not working. We know blood is a scarce source. It's not only in the US, it's really worldwide. And our recommendation is consistent with the British Columbia guidelines for iron deficiency management, that you really should not transfuse unless somebody has hemodynamic compromise or severe signs of anemia requiring correction. That's also consistent with toward optimized practice guidelines. And the last one will be a little very quick, which is focused on idiopathic and autoimmune neutropenia, and basically suggesting that there is really insufficient evidence to use routine GCSF for patients who are otherwise looking healthy and don't have significant severe or frequent bacterial or fungal infections. It should be guided by clinical evaluation. Unnecessary use of GCSF or Neupogen can lead to side effects, especially bone pain and cost. And there were some studies that looked at the utility of anti-neutrophil antibody, if it can really help you predict who's gonna recover when. But I think, you see here like that all of the patients in that study completely recovered, and it really doesn't matter if you're positive or negative, and the ANC at onset also was not statistically significant. And then despite that, I think there was some variability in practice that some people got GCSF up to like 5 months or so, but others got it up to 8 years. But there is really no data, there are no data suggesting that it is actually beneficial.
If you have
this is the last,
half a minute, you have half a minute.
Yes. And this is the last slide actually I have from the Italian registry that looked at their patients with autoimmune and idiopathic neutropenia. And they also have similar results suggesting there are no differences in infections or age at recovery. You got GCSF, you did not get GCSF, it doesn't really matter. And I think you see here there are really no differences in the probability of recovery if you have idiopathic or autoimmune, and GCSF did not change mortality, infection, blood cultures. And there was a similar study done in the US with the same results. I just didn't include it here. So I think at the end, I'm just reminding you with the item, no PT, PTT before surgery, you really don't need it. No platelets unless the patient is symptomatic or you're gonna go for a procedure. No thrombophilia, workup needed for somebody with a CVC clot. Do not do PRPCs, transfusion for asymptomatic iron deficiency anemia, and do not do routine GCSF for somebody who is otherwise without recurrent or severe fungal bacterial infection. And again, thanks for your attention and happy to take questions.
Great talk, Sharif. And choose wisely is you don't have the right to choose except wisely. So you should know the guidelines, you should avoid harm. And I'll take the opportunity and ask James the first question. For how long, James, you give TPO receptor agonist, and what is the best way you go down gradual tapering, then you stop it? What's your opinion?
Well, that's a great question because that's very widely debated. In general, if the patient's count is adequate, you could try to reduce the dose a little bit, whatever a little bit means, see what happens and keep trying to go down. If the platelet count then falls to a level below what you think is adequate for them, then you may have to increase again and wait a while. Could take months, could take years, but the good part is doesn't seem to be any increased toxicity with longer treatment. So maybe taking your choose wisely format, there's just an expense toxicity.
The question for you, James, do you give the COVID vaccine for ITP patients?
Yes, we recommend it, and I say we, it's the Medical Advisory Board of the Platelet Disorder Support Association. And I put in the chat a Platelet Disorder Support Association has a webinar from February 22nd that provides data. We think that not more than 10 or 15% at the most of ITP patients will have an important drop in their platelet count. And fortunately, it appears very treatable and temporary when it occurs.
Last question for Sharif. What do you believe, Sharif, for the iron deficiency anemia? What's the percentage of the 5 choose wisely reduction in transfusion and in PT, PTT? Because there is a good outcome of the choose wisely campaign. So give us a review of that, the value of the choose wisely in the real life.
Yeah, I mean, that's a good question, Professor Al-Alfi. I think, the issue is definitely going to be hard to measure the outcome, right? I think, we know that there is some variability, and especially in the emergency room when people come with severe anemia, especially in the on the young adults or the adolescents, sometimes, in the community hospital, they just may get transfused. So I think it may be like 5 years actually until we see some differences in actually the practice, how people actually do so, by either looking at utilization and correlations with like iron deficiency diagnosis. We likely have to go for what we call here like a secondary data sets and see the association between how many people have an ICD-9 code or a diagnosis of iron deficiency anemia and how many receive the blood in the next 5 years. And hopefully we see that the number for people who have the two codes for transfusion and iron deficiency start to decrease kind of over the next 5 years. So I think there is really no other way for us to try to figure out in more details.
We have to close this session, but before that, I would like to thank James, Sharif, and all the chairs, Professor Tantawi, Professor Assam Abdelwahid, Professor Ahmed Mansour, and James. And thank you very much. We will have now a symposium on hemophilia. The chair is Professor Iman Ragab, and the speaker is Professor Amira Adli. And any one of you, if you have time, please keep on watching this very important symposium. Thank you.
Thank you very much.
Thank you very much. Thanks.
Thank you, everyone.
Dr. Lafi, should I start the symposium up front?
Yes, please, go ahead.
Okay. Bismillah ar-Rahman ar-Rahim. I'm very glad to present the symposium now. First of all, I'm very proud to be part of the hemophilia team in Ain Shams University. The team is growing and it gives very good, comprehensive, multidisciplinary care in hemophilia field. It's progressive. It's involving many subspecialty, very interested in hemophilia care, like orthopedic surgeon and sonographer and specialized nurse, and we are very grateful for our nurse for this. And I'm very honored to present my friend and colleague, Professor Amira Adli. She's a professor of pediatric at Ain Shams University. She's well known in the hematology family in Egypt. And apart from being one of the crucial member in Ain Shams University pediatric hematology group, she's well known by sharing in very distinguished international clinical trials in the thalassemia, sickle cell, and Gaucher disease. She has more than 70 international publications in the field, in the pediatric hematology field, and she's been awarded by very important scientific award in the pediatric research. And she'll be talking about the management of hemophilia, a bird's eye view. And Professor Amira, we are all ears to hear you.
Thank you so much, Professor Iman, for the, yes, you are hearing me?
Yes, Amira, share your presentation.
Yes, I am.
Professor Amira is awarded the جائزة الدولة التشجيعية since so many years, and a lot of awards. Professor Fakhri, Professor Ihaq Gamal, Professor Khalifa, and many of the Espho. And when you are ready.
you're seeing my slide now?
But we're seeing the.
You are hearing me?
We hear you, but
Dr.
we
Amira,
don't see the presentation.
it's you're sharing the screen.
The
not the
presentation is apparent. Okay. Now the presentation is apparent.
No,
Professor Amira, just open the presentation. Stop sharing, open the presentation, and then share again. It would be much easier.
Okay.
Open the presentation on the desktop. And then from the big window, after sharing screen, you will choose the presentation.
Now the presentation is apparent.
Yes, thank you so much. Yes.
Okay. Sorry for the delay. First of all, I would like to thank the organizing committee of this great scientific conference for giving me the opportunity to share in this event. I would like also to thank all the hematology oncology department, everyone who is giving me the chance to learn, educate, and making my research. And thank you so much for my dearest colleague, sister, Professor Iman Ragab, for the introduction. She is actually my mentor. She is honest, sincere, and hard worker in not only in hemophilia, in oncology, and all the hematology department. I will talk today briefly about the management of hemophilia A, a bird's eye view, because I will make just a spotlight only on the management of hemophilia A. Why hemophilia A? Because hemophilia is an underestimating disease. Hemophilia is 3 times more prevalent worldwide than we thought. And why hemophilia A specifically? Because of the disease burden. This disease with bleeding-induced hemophilic arthropathy results in a chronically painful and debilitating condition which requires orthopedic and physiotherapy care beginning at a very young age. Also severe, deep internal or intracranial bleeding and treatment-related complications, either infections or inhibitor developments, with costs of the patients contribute to the total burden of the disease, making hemophilia one of the most expensive diseases with substantial social and financial consequences. So it has a very high disease burden, heavily influences patients' quality of life, psychological well-being, social employment, and seriously impairing the productive of these patients. Hemophilia A is the commonest type of coagulation factor deficiency. It's called the classic hemophilia. It's also one of the most painful diseases due to massive bleeding in the joint and muscles. And also it is 5 times more common than hemophilia B. Regarding the differentiation between hemophilia A and hemophilia B, hemophilia A is mainly more prevalent, with prevalence 1 in 5,000 male compared to 1 in 30,000 male in hemophilia B. Both their mode of inheritance is X-linked recessive, and the clinical symptoms are the same, but the genetic defect in hemophilia A is mainly inversion, and the genetic defect in hemophilia B is mainly missense. Another important differentiating point is the concentration of factor VIII in the plasma, which ranges from 0.1 to 0.25, and factor IX, which ranges its concentration from 3 to 5 microgram per milli. What are hemophilia? Research is to develop a therapy capable of preventing bleeding and its associated complications. 2 primary types of therapy are available for hemophilia: factor replacement therapy and non-factor replacement therapy. The factor replacement therapy use either recombinant or plasma-derived molecules to increase the clotting factor in the patient's plasma. Both standard and extended half-life factor replacement therapy require intravenous infusion, and the standard half-life therapy are used to treat hemophilia A, B, and sometimes of one very blunt disease. although the extended half-life therapy have been modified to delay the breakdown of clotting factor in the body and are primarily used as hemophilia A and B treatment. Non-factor therapy than the clotting factor infusion, such as desmopressin, aminocaproic acid, and imsizumab as a prophylactic protein that performs the task of factor 8 in the clotting cascade. And there is also a novel or mechanistic approach for hemophilia A therapy, such as antithrombin or tissue factor pathway inhibitor, monoclonal antibodies, which seems to lower the endogenous anticoagulant. These approaches are updated, recent, and important, although still associated with risk for thrombogenicity and still working on it to be more safe. The
Professor Amira, can you share the screen?
I guess there was problem with the internet connection because the sound cut with the presentation at the same time.
presentation again appeared. Is the screen is apparent?
Yes,
Yes,
Amir.
that's it.
So successful gene therapy for hemophilia then represents a change in the way people living with hemophilia and improving their quality of life. This is improves the normal clotting mechanism, starting by response to vessel injury. When vessel injury occurs, there is vasoconstriction to reduce the blood flow, then platelet plug formation, and then activation of the clotting cascade with generation of fibrin clot, and ended by fibrinolysis. The clotting cascade normally is the ingredient called factor act like a row of dominoes toppling against each other to create a chain reaction. If one of the factors is missing, this chain reaction cannot proceed. And this is the clotting cascade, both the intrinsic, extrinsic, and the common pathway. And the intrinsic pathway, as you all know, starting by the endothelial damage, factor 12, factor 11 to active factor 11, and factor 9 to active factor 9, and then become the rule of active factor 8, which activate factor 10 to active factor 10, ending by the common pathway and forming the stable fibrin clot. When there is a defect in factor 8, it interrupts the intrinsic pathway, leading to defective formation of the fibrin clot. So hemophilia, which is the shortening of the coagulation factor, and the most common is hemophilia A due to defect in factor 8, had a varying degree of severity, either normal, mild, moderate, or severe, depending on the concentration of the factor 8 in the plasma. Its normal range from 50 to 150 with normal coagulation factor. In mild hemophilia, ranging from 5 to 50%. Bleeding problem usually associated with tooth extraction surgery and severe accident. Moderate hemophilia with 2 to 5% bleeding usually associated with injury and can present like severe hemophilia, and in severe cases with factor less than 1% bleeding is frequent and often spontaneous into joints, muscles, and in any site, including the brain, usually diagnosed very early in the first year of life. And this is a schematic diagram just to say that hemophilic patients bleed for a long duration, maybe till death, because in normal population, when bleeding starts, vessel constricts, platelet plug formation, and then fibrin clot. Although in hemophilia patient, there is incomplete platelet plug and incomplete formation with fibrin clot. This is a diagram just to show the factor 8. It has a heavy chain and a light chain and the connecting beta chain. And this is important when we will talk about the recombinant factor 8 formation. The role of factor VIII is synthesized in various tissues, including the liver, kidney, spleen, as an inactive single-chain protein. After many processing, factor VIII is released into the circulation. This factor VIII molecule interact mainly with von Willebrand, which produced and secreted from the vascular endothelial cells, triggering the coagulation cascade and subsequent generation of serine proteins. Factor VIII is subjected to proteolytic cleavage and associated with dramatic changes for its molecular properties starting to occur, including mainly dissociation of factor VIII and development of the biological activity after it dissociates from the von Willebrand factor. After conversion into its active form, factor VIII then reacts with active factor 9 and the factor 10 to activate factor 10 and continue the coagulation cascade. Current hemophilia therapy has two major concerns and two major goals. The two major concerns is that mainly we have two important problems. Some patients will develop neutralizing antibodies during the first 15 infusion of therapeutic factor VIII, and second is that administration is mainly intravenous, and this will require placement of a central venous access device and may have life-threatening risks of both infection and thrombosis. The two goals, the first one is to provide sufficient factor VIII to prevent spontaneous bleeding, and the second to provide sufficient factor VIII to have normal coagulation function after any trauma. However, the replacement therapy requires tremendous resources for effective use and remains have extraordinary expensive. This is the timelines and events for the journey of development of hemophilia A treatment. It started in 1940s by whole blood as a treatment, then fresh frozen plasma, cryoprecipitate, plasma-driven factor VIII concentrate, heat-related plasma-driven factor VIII. It's mainly divided into on-demand therapy and prophylaxis therapy. On-demand therapy with replacement of factor VIII concentrate infusion, treatment in response to acute bleeding. This, despite enabling bleeding cessation, does not substantially affect the deleterious consequences due to blood accumulation in the affected joints that triggers arthropathy. Prophylaxis, long-term regular factor VIII administration given to prevent or minimize the number of joint bleeds and limit all the deleterious effect of hemophilia. So, hemophilia prophylaxis radically transformed the natural history of the disease with growing evidence, including and leading to better clinical outcome with much earlier institution of the prophylaxis therapy in hemophilia is divided into three parts. Early prophylaxis started before age of 3 years for the second joint bleed is currently the evidence-based gold standard approach in severe hemophilia to preserve normal musculoskeletal function. Second prophylaxis started later in childhood before the onset of the documented joint disease to prevent further bleeding and prevent target joint. Tertiary, if initiated when arthropathy is clinically detected to prevent or delay worsening of joint disease and other more.
The bad connection is everywhere.
Yeah.
I hope Amira is coming back, and Iman, if you have any comment.
Nothing. I was mentioning that we are going through a very good service now because of the prophylaxis. You were giving prophylaxis large number of patients either with the regular factor VIII or the other agents. I'm just talking till that Professor Amira get connected again.
Amira is coming back.
Okay.
Dear Professor Amira, sometimes because of the net trouble, we can stop sharing the video to make the voice of much better quality in the presentation. Professor Amira?
As you all know, okay, go ahead.
This is Hemophilia 2017 about the cost effectiveness analysis between late treatment and the and confirms that prophylaxis started earlier in life have a better quality of life and improvement in patients' morbidities and psychological, and also it has a good impact on the
Dr. Amira,
Dr. Amira, you have to move from the place you are and go to a better place with better.
And while waiting for Dr. Amira, I was mentioning that the prophylaxis, even with secondary and tertiary prophylaxis, made a marvelous change in the patient's life. Yeah, I guess we all noticed in the group in Ain Shams University the change they are more like feeling confident and relaxed being treated with the prophylaxis program. We are recruiting more patients now because of this. I guess the connection. Yeah, I have the same problem with the connection the last day. We're giving actually twice weekly transfusion for most of the patients, except if the patient has breakthrough, we shift to 3 times weekly. Most of the patients are receiving 50 units per kg per week. I guess Professor Amira will mention this in the presentation. We're giving low dose prophylaxis, and they are doing great with this. Dr. Khadija is writing in the chat. I don't know.
Netherlands and Switzerland, all the hemophilia populations are on primary prophylaxis. And so I guess with the separate trial, we start to put many patients on the primary prophylaxis and secondary prophylaxis. And then Professor Tantawi and Professor Iman Ragab and Salwa are continuing giving a good bunch of patients. You have
the presentation is back?
Yes, he's back. You have 2 minutes.
Okay. The second major breakthrough is in the treatment of hemophilia is the development of recombinant factor 8, and recombinant factor 8 is mainly approved in 2008 and produced using an albumin-free cell culture process and is currently available as beta domain deleted recombinant factor 8. And we have 3 generations of factor VIII. First generation using animal-derived proteins in the cell culture, medium and human serum albumin in the final formulation. Second generation product using human-derived protein in the cell culture, but no albumin. And third generation is the most important, manufactured with no amino acids relating to human or animal. And it is either full length, beta domain deleted, or beta domain truncated. And the most important is that the beta domain chain is not important for the coagulation activity of recombinant factor VIII. So its deletion or truncation has no effect on the activity of factor VIII. This is a very important slide, and it shows that the importance of prophylaxis on the outcome of the disease therapy. The primary prophylaxis before second joint bleed, it leads to near normal musculoskeletal psychosocial development. Secondary prophylaxis after second joint bleed, it leads to minimal musculoskeletal disease. Tertiary prophylaxis improves the normal activity only of the daily lives. Short-term prophylaxis improved target joint only, and episodic treatment or on-demand leads to treatment of pain and serious bleeding. This is the factor level we want to reach in different bleeding places and modalities. When there is only joint place, we need to make the desired level of factor VIII from 40 to 60 international unit. And if the bleeding in the superficial muscle, also from 40 to 60, but up to 2 to 3 days every 12 hours. In bleeding of the iliopsoas muscle, which is huge internal muscle, we need to elevate the factor level from 80 to 100% in the first 2 days. But in CNS through GIT, all this internal bleeding raising the factor level from 80 to 100%. The important problem is the development of inhibitors, and the development of inhibitors is mainly related to genetic factors and environmental factors. The genetic factors in factor VIII gene and the immune response genes, and the treatment-related factors, the type of the prophylaxis and either continuous or intensive treatment, and the immune system challenges also related to the environmental factor which develop the inhibitors. So the treatment of inhibitor is mainly the immune tolerance and giving something which bypass the inhibitor. And agents that bypass the inhibitor as recombinant activated factor VII and activated prothrombin complex is available, but the safety margin and the occurrence of thrombogenic complication is still an important problem. So induction of immune tolerance is the main treatment option for eradicating inhibitor and has a high success rate reaching to 80%. The beta domain deleted recombinant factor VIII is now the mainstay in prophylactic treatment of hemophilia and with less development of inhibitor. And regarding the product, which is one of the beta domain deleted chain, the product is called Zensa. It's an important product and now available since 2008 in the treatment prophylaxis of hemophilia and many clinical trials. I found 6 in the clinicaltrial.gov, 4 of these in the previously treated hemophilia patients, and 1 trial in the previously untreated hemophilia patients, and 1 trial on pediatric hemophilia A. And all trials focus on their primary outcome on the efficacy regarding the reduction in bleeding rate and safety with the reduction in the incidence of occurrence of inhibitors. And all these trials document that it is safe and effective in the prophylaxis treatment of hemophilia patient, improving the quality of life. An important issue is, can we switch the treatment of hemophilia patient from one factor to recombinant factor VIII? And this is an important review which is published in European Journal of Hematology about switching treatment in hemophilia, and it concluded that current evidence doesn't suggest that switching products significantly influence the inhibitor production. And again, another nice article in the clinical investigations which about the switching to recombinant factor VIII prophylaxis, and it considers this recombinant factor VIII, the pharmacological and manufacture process characteristic made it unique by the removal as a potential source of containing animal-derived protein of the mouse antibody in the purification step, and excellent clinical record, making it a one step forward product for the treatment and prevention of hemophilia. Just I want to say that there is a future dream for curing of hemophilia, mainly regarding the gene therapy. Exciting new perspectives are represented as a cure by the gene therapy, as it is a single gene disease. And the dream recently become within 10 years as many researchers acting on hemophilia, because it's a devastating and loady and costly disease affecting the children early in life, leading to impairment of their quality of life. And thank you.
Thank you very much, Professor Amira, Professor Iman, for a wonderful Pfizer symposium. And we will go directly to the next session. And we would like to thank Amira, Iman, and the attendees. And we go to the last symposium of the webinars. And tomorrow will be the face-to-face in Bursaid. I have the honor to introduce my co-chair, Professor Rasha El-Ashri. I hope she is with us. We sent her the email, but I hope she will catch. And the star of the Congress, Professor Galila Mukhtar, she will give her talk on the very important product, the sub-Q product, and she will tell us more and more and more. She has 20 minutes, then we will have, if she can make it in 15, then we will have open discussion till she will end herself. Go ahead, Professor Galila, and share your presentation, please.
Thank you so much, Professor Mohsen, for this invitation. And I'm sorry, I'm at the end of the day. Perhaps sometimes you take a food which is very heavy meal, and then you have to take some dessert. So I hope my lecture will be that dessert at the end of the day, and or otherwise you sleep lightly. It is in a form of a video. You will listen to the video, not myself, but it's only the video will show all my presentation. Go ahead. Thank you. Start the video.
Good evening, everybody. This is my today, MSG in practice, a dream coming true. And me, I'm Professor Galila Mukhtar, Medical School. And this is my disclosure. This topic is sponsored by Roche, and it is for promotional use of the Roche product. The hemophilia journey starts by hemophilia like an old enemy, which is the unmet needs of hemophilia. And secondly, by hemophilia, could it be my new friend? So we have solutions for this. And the real life experience we have about this enemy. The agenda is unmet needs in hemophilia, solutions offered by emicizumab, and true story with emicizumab. Epidemiology of hemophilia is being described as growing patient population, since their number now is worldwide like 400,000 patients, and the incidence in 1 in 5,000, and the prevalence is 1 in 12,000. The patients are living longer because the safer factor concentrate in the more effective treatment for the viral infection. That's why the number is increased. But still, we have many patients still undiagnosed. Hemophilia is a serious and life-threatening disease. Why? Because sometimes it occurs in some dangerous area like intracranial, leaving neurological damage, or the neck and throat, leading to airway obstruction, in the joints with the handicapping, and in the muscle like the compartments like iliopsoas and forearm. There are many physical impacts of hemophilia, like hemoarthropathy, blood-borne viral infection, frequency of the scarring, venous scarring after IV access, and the reduced life expectancy, 5 years less in the hemophilia compared to now. The standard of care, of course, is the prophylaxis, and this is cost effective on the long term because it eliminates the high cost associated with damaged joint and replacement. The prophylaxis, there should be pharmacokinetics, and this means that we have to follow the level, which drops after 2 or 3 days after infusion, and sometimes we have to increase the dose with the increased cost and inconvenience. And by this, we have to tailor the prophylaxis, and the statement "one size fits all" is not a good statement. Instead, we have the personalized treatment according to the condition with the activity of the child, or with the severity of the bleeding, or with inhibitors. And here you can imagine how many prophylactic doses. And again, patients with inhibitors are having worse physical functions, and they suffer a lot. We may find severe bleeding in inhibitor patients. The unmet needs when we are treating the inhibitor patients through the bypassing agent, if they are not all approved for prophylaxis, and they are needed to be given frequently, and it might decrease, but still there are some patients they might bleed. And if we are choosing the inhibitor patient in the ITI inhibitor patient, this is intensive, and it may extend up to 12, 18 months, and it is not all successful and very expensive added to this is the cost of joint replacement and the treatment of. Of course, if we have the IV, IV injection for the treatment, this is what is given usually, but it leads to damage in the veins, maybe a risk of bleeding, infection, and thrombosis. And if we have subcutaneous administration, it will be much better than intravenous administration. By this, we have many challenges like breakthrough bleeding, quality of life impact, inhibitors, and adherence. We need solution from bispecific monoclonal antibody mimicking the coagulation factor 8, which is the emicizumab, and this allows the formation of thrombin through activation of factor 9 and 10 without factor 8. Of course, this is a good prophylaxis way approved by the FDA in 2017 in the inhibitor patient, and in 2018 in non-inhibitors patient. And the dosage is loading dose 3 milligram per kilo subcutaneously for 4 weeks, then 1.5 milligram per kilo once weekly, or 3 milligram per kilo every 2 weeks. They happen studies in adults with inhibitors, in pediatric with inhibitors, and in adults without inhibitors, and adults and pediatric without inhibitors. All they were using the same loading dose as 3 milligram per kilo every week for 4 loading dose, but in 1 and 2 they used 1.5 milligram per kilo every week, and in 3 they considered using this every 2 weeks, and in 4 they considered using this every 4 weeks. This was quite satisfactory in Heaven 1 because the primary endpoint was reached by decreasing annual bleeding rate, and the secondary endpoint by reduction up to 0. And the common side effects were local, except in some cases with thromboembolic manifestations, and definitely there was of life. Having 2 had a similar condition in pediatrics, and it prevents or reduces bleeding, and with minimal side effects. 3 and 4, they got the same results while using the factor every 2 weeks in Heaven 3 and every 4 weeks in Heaven 4, with satisfactory results for 0 bleed and reduction of bleeding and good quality. And of course, the pharmacokinetics was followed, and in those who were using every week were compared to every 2 weeks and every 4 weeks, and definitely the level was the same in. So the emicizumab offers some solution for repeated venous access by once subcutaneous and too many doses by once weekly, and the patient adherence once weekly. The quality of life improved, but still with the cost, there is some debate, and the development of inhibitors already it is used in inhibitors, and the efficacy of others it has a longer. Here we have real life experience offered by Professor Iman Ragab, a professor of pediatric hematology, Children's Hospital. This is our patient, and our patient is now 16 years 4 months, and he is the second of order in birth, and he had hemophilia with a level of 2.6%, and his brother had hemophilia with a level of 2%. This brother had intracranial hemorrhage, severe annual bleeding rate, target joint, and the life timeline of this our index patient. He had scalp hematoma in 2007. Treated by cryopreceptor, then scalp hematoma repeated, and then he got transient inhibitor in 2008. Then he had the annual bleeding rate of 5 to 6. At August 2014, he had infected iliopsoas. It was treated, and then he was followed in 2015 with the inhibitor reaching to 101 per unit, and he presented with acute abdomen, a marked pallor, abdominal tenderness, and in October 2000 he had this CT pelvic abdomen and revealed psoas accumulation. And he had to receive the factor 7, and it cost about 372,000. Follow-up ultrasound, there is loss of extension angle and follow-up physical. He developed new. We decided to shift to Hemlibra with the dose of 3 milligram per kilogram per week for loading, and 1.5 milligram per kilogram every week for maintenance. And here is the result of this child and or young guy, and he had good satisfaction and good quality of life. And by this, we were satisfied and continued condition. And finally, we put the aspirational goals beyond the current treatment, like more convenient dosing, reduced treatment cost, annual bleeding rate 0, improved quality of life, consistent pharmacokinetic, no joint damage, less invasive mode of administration, spontaneity in life, no immunogenicity, no limits on work, school, or and by this we stop bleeding and save their life. And I Good evening, everybody. This is my topic today, emicizumab impact.
We can share the video, please, Mr. Gavi.
There is a video for this young chap, and it takes about half a minute.
Okay.
Please put the video, yes. The video is not shown.
Yes, our IT coordinator, Mr. Gafi, is going to share it now.
Okay.
I think the internet connection for all of us today is a bit horrible.
And that's why I made my presentation like a video to be more convenient for all of you.
It is very nice to see you, the Professor Galil.
Just a clever idea. Okay, we can proceed until the video is available. Professor Alfie is going to chair this session and continue with the puzzling questions I put, like using young children or in surgery or whatever he wants to direct. This is the video here.
اخبار العلاج ايه يعني انت بدأت بقالك قد ايه؟
بقالي كده داخل في الشهرين.
في شهرين. هل حصل اي نزف في الشهرين؟ لا. انت نشاطاتك اللي بتعملها ايه؟
دلوقتي بقيت اجري حلو يعني.
لا مش يعني هل بتعمل حاجة عنيفة، اي حاجة رياضة عنيفة؟
انا بشيل حاجات يعني بس مش تقيلة قوي.
مش تقيلة قوي. طيب احكي لي يعني هل ما حصلش اي نزف في الشهرين؟ لا. هل بدأت علاج طبيعي الاول ولا لا؟
لا.
لسه ما بدأتش. طيب ايه الحاجات اللي انت يعني حاساها ملحوظة في تحسن فيها؟
رجلي دلوقتي نزلت كتير وبقيت امشي حلو على الاول، مبقتش اعرف خالص، بقيت امشي حلو يعني، وما اتأذيتش في رجلي، حتى لو اتخبطت فيها ما بتوجعنيش ولا حاجة.
طيب ممكن اسأل سؤال؟ انت النزف كان قبل ما نبدأ العلاج هل كان في نزف بسيط بيحصل؟ حتى لو مش نزف يتحجز فيه مش تتحجز؟
ما اتخبطتش حتى، بحس بنزف، بحس بتورم لوحدها.
طيب
Thank you so much. You can proceed with the session. Thank you.
I welcome Professor Rasha Al-Ashri. Professor Rasha is the head of the Pediatric Hematology Oncology Mansoura University. He is co-chairing this session. Professor Rasha, do you have any comment on the presentation of Professor Galila?
I have the honor to be involved in this issue.
يعني حاولي تظبطي.
Hello, Professor Galila. Hello, Professor Dr. Mohsen. I have the honor to be involved in such an event.
رشا اظبطي الصوت، حاولي تظبطيه، يعني انا هتكلم وحاولي تظبطي الصوت وخديجه هتحاول تعمل كونتاكت معاك.
Okay.
Actually, I think Professor Ahmed Mansour has experience he would like to share with us. If Professor Ahmed, you are ready, you can share.
Yes, I am ready, Dr. Mohsen, and very thank to Dr. Galila to this excellent presentation. الحقيقة احنا في المنصورة كان عندنا أول حالة without inhibitor، بدأناها في 12/2019. حاليا بقى لنا سنة و4 شهور دلوقتي بتاخد العلاج. الولد ما شاء الله without any bleeding attacks، zero bleeding. كان عنده more than 6 joint affected. حاليا دلوقتي يعتبر free. بيمارس رياضة خفيفة جدا، بيمارس تنس أرضي، ودي حاجة ما كانش يحلم بيها. الحمد لله في شهر 12/20 بدأنا حالتين أقل من 6 سنين، حالة أقل من 2 سنين، وحالة أقل من 6 سنين 4 سنين و7 شهور. الحالتين بقى لهم دلوقتي حوالي 3 شهور under treatment after induction، وماشيين على الريجيم اللي هو الاندكشن once weekly، وبعدين بناخد نفس الدوز every 2 weeks. الحقيقة طبعا ال3 حالات well done without any complication. كان فيهم حالة الأولانية دي كان فيها intracranial hemorrhage at the age of 6 months، وفضل في الاي سي يو حوالي أكتر من شهر. الحمد لله دلوقتي زي ما بقول لحضرتك ما عادش بياخد حتى فاكتور، ما عادش بياخد أي ريبليسمنت ثيرابي. طبعا احنا بنهوب ان هو يبقى مصرح بيه في التأمين، وبنهوب ان شاء الله ان هو تومنتين العلاج لأكبر عدد ممكن من الأطفال اللي محتاجينه. وانا عارف من التأمين ان شاء الله لو الدكتورة نجلاء مشاركانا ان هو هيصرح بيه في خلال within this week or the second week، وان شاء الله يبقى مصرح بيه للأطفال في كذا مرحلة with inhibitors without inhibitor and أقل من 6 سنين، وبعد كده يبقى أكتر من 6 سنين. فده بيتهيألي كانت الاكسبيرينس بتاعتنا لأول حالات أقل من 6 سنين على مستوى مصر كلها، بيتهيألي هم دول أول حالتين نبدأ لهم، وكانوا فيهم حالة خدت أكتر من 20 مرة فاكتور، والحالة الثانية خدت twice only فاكتور due to elbow affection. شكرا لسعادتك.
شكرا يا دكتور احمد. الحقيقه انه ما فيش كلام انه حصل بريك ثرو. كون ان انا ادي انترافينوس المفروض في الاصل ان هو يبقى ديلي، بيتاخد every second day او twice per week او Canadian protocol once per week till there is episodic bleeding. We go for twice per week or 3 times a week intravenous. This sub-Q, and as you mentioned, Ahmed, for the first period for the initiation, we give it weekly to build up, then 3 milligram, then we go to 1.5 per kg every week or 3 every couple of weeks. My patient, I think, was the first, maybe the Roche team to correct that. It starts maybe in November 2019. And he's actually very regular. And it was amazing that he said for the first time, when I walk for long distance or I do sports, I don't have to have the intravenous shots. And his quality of life is extremely improved. Actually, he gave me the confidence of the drug even more than the name of Roche. Which is very trustable, but I trust the patient and I trust the family. A big change in his quality of life. Professor Rasha, if you have any comment, go ahead.
صوت يا دكتورة رشا. صوت.
اعملي نفسك unmute يا رشا.
How many patients do you have in Ain Shams? Total number of patients on imizumab.
Professor Iman is with us. I have my patient. One patient, actually, it is a private case, and now he is 15 months, and Iman has three cases.
Yeah.
3 cases.
Yes.
Yes.
We are trying to add more because this is all coming from charity and the non-governmental agencies. But if this will be allowed by Ta'min, it will increase more than this because we have a waiting list, long waiting list.
Iman, could you
Yes, and the one we have actually 1 4 years.
Only one, Iman? Only one?
No. We have 2 patients. The one Professor Galila presented has actually 8 months treatment. You have another one with 4 months treatment, and another one about to be started very soon, inshallah.
Those with inhibitors or without inhibitors, Iman?
All of them with inhibitor positive.
And the point is the changing paradigm of hemophilia management. I think when the price will become subsidized, this will be treatment of choice for all hemophilics, whether with inhibitors or without. But now we start with patients with inhibitor. My patient has inhibitor, and I try with him ITI. It was successful actually, but I start the imizumab before the end of the ITI, and now he is maybe 18 months, coming to 18 months on therapy twice every 2 weeks, sub-Q. Is very happy, and we are all happy. If anyone from the floor would like to share experience with other patients, or you would like to ask Professor Galila or Professor Rasha or myself. Khadija, any questions from the floor?
No, until now there are no questions.
The only coming thing is after is using during surgery. And it's advised in minor surgery, we can use it alone. But in major surgery, it should be supported. If the patient is with inhibitor, we have to give the bypassing agent. And if he is without inhibitor, we have to give added factor 8. And I think some of our professors had already started using the emicizumab with minor like tooth extractions or something like that. And it will follow next year. Perhaps we we are admitting a lot of cases because of this new change in therapy. Thank you.
I guess Professor Galila means that patients on minor surgery and on treatment on emicizumab is allowed, because we don't give it specially for the minor surgery. The patient is on treatment. Then if he has minor surgery, he doesn't need any boost from factor VIII. However, major surgery, still there are clinical trials.
This is the point. Thank you.
If all can open the camera, I could take a group photo.
We can have one last question for Professor Galila. Yes. When do you think it's going to be covered by the insurance and not only by charity or personal support?
No, it's very soon. I think it's accepted up till now to be the mainstay. And Professor Nagla Shaheen, she promised that it will be available very, very, very soon.
Yeah, to answer the question, Khadija, it will be step by step. I mean, now all patients in Egypt having emicizumab is only like 35, 40 patients, maybe less than 50. We have more than 5,000 patients. So if we go from 50 for the coming year to 100, it will be a great achievement. In 2 years, if we become to be 200, it will be great, and so on. But it could never be more than big jump.
This will be decided by a higher counselor. It will not be for everybody, but at least it will be available for those who are in high need of it. Thank you.
Actually, they have a total budget, but to answer your question, Khadija, it is usually step by step. So if we open, Nagla, if you are there, Professor Safinaz, Fatma, Iman, to take a group photo, if you are there. No? Iman, yes. And Professor Muhammad. Hi, Muhammad.
هاي
منور الدنيا. ايوه كده. الفيس شيلد والدبل ماسك ولا سنجل ماسك؟
لا، مع الفيس شيلد سنجل ماسك.
دبل ماسك. Nihal, if you are there, Salwa is not joining, Iman, ولا ايه؟ Open your mic, Iman.
كانت سلوى موجودة، أنا بشوفها. نهال موجودة.
اوكي.
مش عارفة سلوى فين. بس هي كانت موجودة، كانت حاضرة يعني.
بتهيألي سلوى موجودة يا دكتور.
تمام. Any last comment, Professor Ahmed or Professor Rasha or Professor Galila? Professor
I think time is over.
منورة دكتورة صفيناس.
الله يخلي حضرتك.
Okay. I would like to thank Roche and Pfizer, Professor Galila, Professor Rasha, Ahmed, Iman, all the panelists. Special thanks to Professor Khadija Tumbari, Professor Amira Abdelmenam for giving huge support for the Congress. Ahmed, my elder son, I consider him, Ahmed Fathi. Professor Iman did 2 big sessions this year, the non-Hodgkin lymphoma Ain Shams Dallas session, and Professor Tantawi did the Harry Potter, then the palliation therapy, Iman Ragab and Khadija Tumbari. Professor Fatma give the clinical trials in Ain Shams University experience. Mansoura has a lot of publications and of support for the hematology population. And I would like to thank Nagla Shaheen for all the efforts she is doing for the hemophilia patients, and all Ain Shams team or Espho board members, Professor Galila, Professor Tantawi, Professor Ikiabi, Professor Badr, Professor Ahmed Mansour, Professor Nagla Shaheen, Professor Oda Hassab, Ala Haddad, and all Espho board. And tomorrow we will have 2 sessions in Bursaid. I hope we meet there, enjoy, and I think all of the attendees are invited. Khadija has family issues, so she's not coming, but we will, when we eat the the fish, we will remember that you should be with us. And when we take photos and the ride, we will remember that you should be with us. Thank you very much, and see you next Espho, and see you tomorrow in Bursaid. دكتورة جليلة تقولي حاجة؟
تصبحوا على خير. كلكم تصبحوا على خير.
على خير.
نوما هادئا سعيدا بعد اليوم الحافل العظيم.
آمين يا رب العالمين. ألف شكر يا أحمد، ألف شكر يا رشا، ألف شكر دكتورة
شكرا
خديجة وإيمان وفاطمة ومحمد عبد المحسن ونجلاء شاهين والجميع.
شكرا دكتور محسن، تصبح على خير.
تصبح على خير.